The Wellness Hour. An in-depth discussion with today's top physicians and medical leaders. And now, your host, Randy Alvarez.
You're watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, new breakthroughs in the treatment of low back pain. With us, we have an expert on the topic, Dr. Verdolin. Dr. Verdolin, welcome to the program.
Thank you very much for having me.
Now, your practice, Pain Control Associates of San Diego. Tell me a little bit about your practice and a little bit about your background and training.
My background, I actually trained with the United States Navy. I went to medical school at the University of Miami and graduated in 1996. And the United States Navy was kind enough to pay for medical school, and I was kind enough to pay back, and did my training in anesthesiology as well as interventional pain management fellowship with them at Walter Reed Army Medical Center.
You were head of their pain center, is that correct?
Well, I was, when I finished my training, I was brought to San Diego in 2004 and took over as the head of the pain management clinic at Balboa Naval Medical Center.
How does that give you a unique experience that's different than most guys? Because you're dealing with a lot of young guys in a lot of pain.
I would say that, unfortunately for the situation at the time, it did give me a fantastic opportunity to see folks that went from having no pain to having extreme pain. And what I mean by that is the patients were active duty Marines and sailors who had been wounded in war, and gave the opportunity to actually work on their pain problem in a very aggressive fashion and bring them back to a quality of life that they had before their traumatic incident. And so I would say that that is a very different experience than most pain physicians who don't have that opportunity in the military.
Okay, now your practice, who's the typical patient in your San Diego practice?
Well, since I left the Navy in 2007 and opened my private practice in San Diego County, most of my patients tend to be retirees and older patients who have a different set of problems than the younger patient who might have an acute or immediate injury. So basically in chronic pain, to develop chronic pain, you have to have an acute injury or an immediate injury, and those damages last for a long period of time, or the natural process of aging, which causes damage to the skeleton and to the spine in particular. So I would say 70% of my patients come to see me for low back pain.
So you are an interventional pain management specialist.
So specifically what interventional pain management means is I do not only medication management and coordinate with physical therapy and other modalities, but I also do treatments, procedural interventions, including injections, which many folks have heard of, epidural steroid injections. But beyond that, there are now new opportunities to actually cure some of the issues that are causing that chronic pain.
Interesting. Okay, so spinal stenosis, one of the topics we're talking about today. What is it?
Spinal stenosis, you've seen these patients, you may be these patients. You see them at the grocery store bent over the shopping cart because they can't stand up straight. If you suffer from spinal stenosis, you walk 10, 15 feet and you have to sit down to relieve the awful low back and radiating leg pain. What's happening in spinal...
So standing up straight for these people is just painful, very painful.
It's practically impossible.
Okay.
And part of the reason for that is it's basically arthritis of the spine. And everybody has heard of what is arthritis. Arthritis is when any joint in the body, be it knees, toes, fingers, elbows, start to break down. And instead of having that lubricating capsule that allows for movement of the bone, you have basically rust in the hinge. And so the bone doesn't move as well. And what most people don't know is we have 33 pairs of joints that run from the base of the skull all the way down to the tailbone. And so in spinal stenosis, it's these joints that start to overgrow, almost like sand causes a pearl in an oyster. So I often tell my patients with spinal stenosis, they have a string of pearls basically growing in their spine. And the problem is those overgrowths squeeze and choke the nerves that are trying to exit. So that explains why they end up with radiating leg pain, typically into both legs.
Okay, now what kind of Medicare-approved treatments are there?
Exist for this at this time? Medication management, physical therapy. Sometimes they get referred to pain doctors like me, and we do epidural steroid injections. Steroid injections simply mask the symptoms, they reduce inflammation, and they work pretty well for a vast majority of patients, 2 to 3 months at a time.
Okay.
However, it doesn't cure anything. So you asked me Medicare-wise, what is covered as a curative procedure? Well, up until recently, all there was open back surgery. That's where the referral went to the orthopedic or neurospine surgeon, and an incision that was approximately 5 inches long is made in the middle of the back, and all of those muscles are removed from the bone, and then the surgeon, using open vision, comes in with a pair of pliers, basically, to remove the bone.
So they cut out the part that's the nerves are pushed against.
Correct.
Give it more room.
To give it more room.
Okay.
The downside of open back...
But that's effective.
That is effective.
Okay.
It's proven effective. And it does have some downsides.
All right.
So, like I said, up until recently, that was all that was available.
A lot of downtime, though, in that.
There is a lot of downtime. And quite honestly, a lot of potential complications, including tears on the tube that covers the spinal fluid, requiring more operations, infection, return to the hospital, up to 15% of the time. And that's in the New England Journal of Medicine. It was published. It's called the SPORT trial, in case the viewers want to look that up.
Okay. So this new procedure that you're doing, so how is it an improvement upon that other more invasive cutting procedure?
Well, now Medicare actually approves something called minimally invasive lumbar decompression. So we're decompressing that central canal, removing those pearls, like I said, without an incision. Just like heart surgery used to be open surgery, now interventional cardiologists in the last 20 years are doing remarkable things to open clogged arteries. This is a procedure to open the clogged spine. And so,
interesting.
Instead of making a big incision, it's just a small 5 millimeter, and that is basically a 1/4 of an inch incision to pass a very tiny tube down into the area in question. And I'd like to point...
Sure, let's take a look. You brought some slides?
I brought some slides. I'd like to point out that historically, as mentioned, for Medicare-approved and insurance-approved treatments, this is what was done. Conservative therapy that involved physical therapy, medications like Vicodin and other narcotics with some side effects that are unpleasant or undesired. The epidural steroid injection, which is very effective but doesn't cure anything. Then typically we would go to what we call a laminotomy or laminectomy, which is what the surgeon would do in that 5-inch open incision. Now there's a...
Now, what's the downtime, by the way, on that laminectomy?
On the laminectomy, it's a minimum of 2 to 3 days in the hospital.
Okay.
And then up to a month of recovery time afterwards.
All right.
During which infection can occur, leaks can be identified, and the need to return to the hospital is up to, like I said, 15%. So this particular treatment fills a gap between the epidural steroid injection, which is simply a Band-Aid, so to speak, compared to an open back surgery. So there was a treatment gap identified.
But nobody wants that surgery.
I would say most people don't want an open back surgery if they can help it.
Okay.
Typically because of the known complication rate.
So your mild procedure. This is what is this we're looking at?
We're looking at a typical patient who would benefit from mild. This is an MRI slide, and basically it demonstrates that the central canal, right where the nerves are being compressed. Normally that should be a big open circle, and instead it's a small triangle. And you can see from the back side here that the narrowing almost occurs like a set of curvaceous wastes, which you don't want. You'd like to see a nice smooth banana, so to speak, back there. That's the canal that we're talking about, like the artery in the heart that is compressed and closed. So the idea of the procedure is to remove that material that is compressing the canal. And this is a slide demonstrating specifically how small the entry is. So instead of making an incision from here to here, which is what the surgeon would do, it's a 1/4 inch portal. And that's all that's done. Very
similar. How are you able to remove the bone, though? I mean, how are you able to...
Well, here's an X-ray.
A laser at the end?
It's not a laser. It's actually a miniaturized surgical device. So it achieves the same efficacy. It achieves the same endpoint as the open surgery, but because it can be done arthroscopically, or in this case, fluoroscopically using X-ray, and this is the image that I'm demonstrating here.
So you're looking at a machine the whole time?
I'm looking at a machine. I'm looking at what I'm doing the entire time.
All right.
But I'm using X-ray instead of having to open the patient. And so you can see here, this is the device coming out and actually grabbing those pearls and removing them.
And it's just as effective as that open procedure for the same kind of problem.
The data
Is that correct?
The data to date says yes.
Why isn't everybody doing it then?
Well,
the learning curve?
There's a learning curve definitely involved. It's a relatively new procedure, so it needs to have some penetration in the market, so to speak. Certainly,
this is the future, though.
This is the future.
Interesting.
And at the conclusion of the procedure, this is what the patient goes home with. The procedure takes 35 minutes. The procedure is done under local anesthesia, not general anesthesia, so there's no worry about putting breathing tubes in the patient and worrying about anesthetic risks. And the patient goes home with a Band-Aid instead of...
How soon could they walk? I mean, how soon do they report that they feel better?
30 minutes after the procedure.
Really?
And they walk home.
They're standing up straight?
They're standing up straight.
What do they say to you, by the way?
They say, "Oh my God, I can't believe I waited this long to do something about this."
Really?
Indeed.
Really. And so do they need a referral to see a pain management? Interventional pain management specialist like you?
Medicare patients who are not part of an HMO, just have Medicare and a secondary insurance like Blue Cross, Blue Shield, whatnot, they can come.
They can call you directly.
Call me directly.
And if they need a referral, what kind of insurance would that be if you needed a referral?
If you needed a referral, it might be HMOs.
So if you went to your primary care physician and said, "Hey, I want to see the pain management guy, not the orthopedic guy," or maybe both, or at least, I mean, do you think people should see both?
I got to tell you, I want to go back to this treatment gap.
Okay.
And I really want to tell you that it is my firm opinion that a pain management physician should come before a surgical evaluation unless there's a suspected emergency. Because pain is not an emergency.
Pain is not an emergency.
Pain is not an emergency requiring a surgeon unless there is a diagnosis such as a completely unstable spine, which occurs very rarely.
So
in fact, to clarify, the primary care doctors should be referring their patients directly to me first.
Interesting. So you are, people hear about this now how? How do they hear about it now? Not a lot of guys doing this?
Not a lot of guys doing this. Here in San Diego County, my partner and I are doing it, and one other physician.
Interesting.
And unfortunately, he's at UCSD, and for whatever reason, they're having difficulty running the program.
Okay. So I understand this correctly, and people watching this, that every single day, this other surgical procedure for spinal stenosis, okay, is being done every single, maybe 5 a day, 10 a day. That means in San Diego?
At least.
Okay, at least?
By each spine surgeon.
Okay.
And of which there are.
So there could be hundreds being done.
Hundreds of these done.
Every single day.
Correct.
When this new minimally invasive with just a small.
Smaller than your pen.
You leave with a Band-Aid.
You leave with a Band-Aid.
Interesting. I mean, it's hard to believe, but that's good.
But it's the truth.
And you lecture on this topic.
I lecture on this topic.
You're traveling all over the place.
I am.
Teaching other people to do it?
I teach other doctors to do it.
Okay.
So once they achieve privileges at their hospitals, because this has to be done in a hospital currently, then I come and make sure that they're doing it properly. It's called proctoring.
All right. Okay. Final message, somebody watching this. They think they've tried everything. They've heard everything. Their back pain's not going away. They don't want surgery. What do you say?
At least come in for an evaluation. We'll look at the MRI. We'll consider what's been done previously. Because this is for central spinal stenosis, and there may be other conditions causing back and leg pain that may need to be addressed first. So it's specifically for spinal stenosis. So not everybody is a candidate.
What defines spinal stenosis, though? It is, but symptom-wise.
Symptom-wise, it's the inability to stand or walk for any sort of distance, 5, 10, 15 feet. They have to continually sit down to relieve the pain. So pain is relieved with sitting. It's worsened by standing and walking.
And obviously, like anything else, I mean, does it come on strong, or does this something that happen over time?
Well, spinal stenosis...
Like they start noticing, wow, the only way I feel good is sitting down.
That's correct. It's usually a gradual process. So folks may have had pain for 20 years, back pain for 20 years, and they used to be able to walk 5, 10, 15 blocks without having to sit down, and it gradually gets worse and worse. And going back to that treatment gap, it's at that time that they usually get referred to a pain doctor for epidural steroid injections, and so the injections provide them the ability to still walk those 5, 10, 15 blocks. It's when those blocks start becoming less effective and the diagnosis is made looking at the MRI and listening to the patient, which is always the most important part of history, then you start to look at more curative options.
How long have you been doing this?
I've been doing this exactly 1 year in San Diego County. The product's only been available for 2 years, and to date I've treated 70 patients.
And all of them are, I mean, is there a reaction? I should have done this years ago?
Exactly. I'm thinking, why wasn't this invented before? And interestingly enough, of all people that invented this procedure, it was a neurosurgeon who developed it specifically for interventional pain doctors who have the only expertise at working under X-ray, which this procedure requires.
What could the skeptics say about this, by the way? Because
to
me,
be
it
honest,
sounds fantastic. But what could they say?
Well, the skeptics, most of them being
Like medical doctors,
orthopedic surgeons.
Okay, what could they say?
Typically, they'll say, "Well, what is it that you're doing? You're not really doing anything." To which I say, the procedure is done with something called an epidurogram, where I inject contrast dye, and I can see it narrowed in the patient, just like in the heart, when the heart arteries are clogged. You can see that they're narrowed. I remove the bone, I remove the material, and the contrast flows open. There is no discussion as to whether it's effective or not.
So in the future, in your opinion, orthopedic surgeons will be doing this as well?
They may.
They have to. I mean, if it's that effective.
The problem, again, goes back to our roots in training. Surgeons operate in an open environment.
Okay.
They do not operate under X-ray.
So there's a
big
learning
curve. I've done 15,000 epidural injections in my career.
Using an X-ray.
Using X-ray, which, by the way, is the only effective way of doing injections, under some way of actually imaging and seeing where the needle is going.
Very interesting. I want to thank you for coming on the program.
Thank you for having me.
You have a website that they need to visit to find out more?
www.paincontrolassociates, all one word, .com.
.com. I want to thank you for coming on the show. Very interesting. Great
Thank
stuff.
you very much.
You've been watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. If you would like to see this interview again, you just got part of it, you can visit our website at wellnesshour.com and just go under pain management, or spinal stenosis, and of course the doctor's name. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.